Hi guys, I'm Lauren Jones, and today we're going to be talking about locked-in syndrome, also known as LIS. For those of you who haven't heard of it before, I'll give you a quick rundown. Basically, locked-in syndrome causes people to not be able to move or communicate in any way while their brain still works just as well as yours or mine. Scary, right? They're completely cognitively aware of their surroundings, but they can't move in any way, essentially turning their own body into a prison cell. They can no longer perform any daily functions like chewing, swallowing, breathing, moving limbs, and moving their eyes side to side. And I bet by now you're wondering, how is this possible and how can I keep it from happening to me? Well, don't you worry. I'm going to start off talking about the causes and symptoms of LIS, how people with LIS communicate, how they're diagnosed, and their prognosis. Then we're going to move into the question of possible recovery, the emotional states of people with LIS, and improvements in technology that are revolutionary in this field. So first, we're going to talk about how locked-in syndrome is caused. The most common cause is damage to the part of the brainstem known as the pons. The pons is involved in controlling breathing, hearing, taste, balance, and communication between different parts of the brain. The biggest issue in LIS is the damage to the pathways connecting different parts of your brain, because that leads to interruptions in the motor fibers that run from the gray matter of your brain to the spinal cord, and that leads to full body paralysis. Also, the centers in the brainstem that are responsible for speech and facial control are damaged. Damage to the pons can be caused by a few different things. One is lack of blood flow to the brain due to a blood clot or a stroke. Another is hemorrhaging or profuse internal bleeding, which is normally caused in this case by uncontrolled high blood pressure. A third cause can be head trauma, although that's rare. So make sure that you're checking on your blood pressure with a doctor. Now that we know what causes LIS, let's talk about the symptoms of the disease. In LIS, there's a lot of damage to the pyramidal tracts, which connect the cerebral cortex in the brain to either the spinal cord, which is called the corticospinal tract, or to the brainstem, called the corticobulbar tract. The damage to the bilateral corticospinal tract causes quadriplegia, which is paralysis of all four limbs and your torso, making it so that you cannot move in any way. The damage to the corticobulbar tract causes the inability to make speech sounds on command and facial weakness. The reticular formation, which we can see here, is undamaged. The reticular formation regulates the sleep-wake cycle and filters incoming stimuli such as pain, temperature, touch, and other sensory signals. Because this is spared, the patient is fully awake and conscious of what is happening all around them. In patients with LIS, there is damage to the frontal part of the brainstem, which is where the majority of pathways that control our ability to move pass through. This damage stops motor signals originating in our brain from reaching the nerves in the spinal cord that innervate our muscles, so you cannot move. However, the damage is below a certain point in the brainstem, so some nerves are spared. These include the olfactory and optic nerves, which allow sense signals and visual signals to reach our brain, and cranial nerves 3 and 4, which carry signals from our brain to our eyes, so we can move our eyes. One of the scariest symptoms about LIS is the inability to communicate. However, over the years, we've developed a communication system. Patients with LIS can communicate mostly by alphabetical communication charts like the one seen here. There are many variations of these charts, including a verbal listing of the alphabet or use of various grids containing letters in different columns and rows. The patient can make a prearranged and pre-agreed upon eye movement to indicate a certain letter. Some people blink a certain number of times to indicate the row the letter is in, followed by a pause, and then blinking a certain number of times for the column. For example, they may blink once, pause, then blink twice to indicate that the letter is in the first row, second column. So we would look at the chart and write down B and continue. The system is pretty slow, but is very effective and has been the go-to method of communication with LIS patients for many years now. So, if you can't communicate unless people know to show you a chart, how do you tell them what's wrong with you? That's the largest barrier initially facing patients with locked-in syndrome. Because of that, the risk of misdiagnosis is scary high and has devastating consequences for the patient emotionally and physically. Common incorrect diagnoses include a comatose state and a vegetative state. The correct diagnosis is most of the time shown in clinical symptoms rather than by a certain test, even though patients lack the motor responses typically used to measure consciousness. Diagnosis is also complicated by the fact that when locked-in patients first wake up, their brain is functioning at a much lower level because of the huge trauma it just endured. Because their brain isn't functioning at full speed, most of the time they can't show that they can still respond to things and know what's going on. Typically, patients who can't move have their consciousness and comprehension tested by requesting eye blinking or vertical eye movements. Brain imaging, such as a PET scan or a functional MRI, can be used to assess function of the brain. In a vast majority of cases, the first person to realize the patient was conscious and could communicate was a family member rather than the physician attending to the patient. The length of time elapsed from the initial brain injury to the correct diagnosis is on average 2.5 months. Some patients are not correctly diagnosed for years. This enormous length of time is not only emotionally exhausting and excruciating for the patient, but can be detrimental to their recovery overall. Once a patient is correctly diagnosed with locked-in syndrome, physicians try to figure out how this is going to affect the person and their family. The prognosis for patients with locked-in syndrome is really variable and depends on the cause as well as other factors and other potential brain deficits, the level of support that the patient has available to them as far as family and financial support. Features that indicate possible recovery include early recovery of lateral, side-to-side eye movements. Is recovery possible? That's most likely the biggest question asked about locked-in syndrome. A study by Casanova evaluated prognosis and recovery in 14 patients with locked-in syndrome that were receiving early intensive rehabilitative care. Treatments included intensive nursing care and intensive early rehabilitative program, which encompassed physiotherapy and respiratory, swallowing, and speech training. At the end of the multidisciplinary rehabilitation treatment, the results showed general improvement in all areas. Motor recovery was complete in 1 case, moderate in 2 cases, minimal in 8 cases, and non-existent in 3 cases. Similar to cases reported by another study, motor recovery did not include control of the head and trunk. At discharge, 7 of 12 patients achieved stability in breathing patterns after intensive respiratory nursing and training. These patients were then able to have their tracheostomy cannula removed. After swallowing training, only 43% of the patients were able to completely recover swallowing ability for solids and fluids. Verbal communication was partially recovered in 4 cases. This study shows us that the course of the first 3 to 6 months after onset of LIS significantly improved the functional recovery and reduced the mortality rate of patients when rehabilitative care was involved. Taking this knowledge into account and looking back at the high incidence of misdiagnosis goes to show just how important it is to diagnose LIS quickly and accurately. Another huge issue in the LIS community is evaluation and improvement of quality of life. A survey conducted by Bruno wanted to describe chronic locked-in patients' subjective well-being and to identify the factors that impacted their well-being. Using a standardized scale, 72% of locked-in patients declared happiness, while only 28% declared unhappiness. The researchers found a few different factors associated with unhappiness, such as dissatisfaction with mobility in the community, dissatisfaction with recreational activities, and with the capacity to deal with life events. Shorter time in LIS, anxiety, and non-recovery of speech production were also correlated with lower happiness ratings. The variables associated with positive happiness ratings were actually a longer time spent in LIS, absence of anxiety, and recovery of speech production. The study stresses the need for additional efforts directed at increasing integration and mobility of locked-in people and the importance of anxiety control efforts. The future of living with locked-in syndrome looks brighter and brighter every day. Scientists are continuing to develop technologies to make communication easier and more effective for patients with LIS. The two main technologies out right now are eye tracking and mind-controlled computers. The Tobii PCI can track your pupil to control the computer. The person moves their pupil to operate the cursor and on-screen keyboard, basically using a computer just as any able-bodied person can. Mind-controlled computers involve a head cap powered by an EEG machine that's placed on the patient's head. When they imagine moving a certain body part, they activate certain brain waves. Those are picked up by the cap and translated into movement of the cursor on the screen. These technologies allow the people with locked-in syndrome to easier control their environment, use a word processor coupled to a speech synthesizer, and access the internet. These innovative technologies can significantly increase quality of life for people with locked-in syndrome.